Did you see? So we got through paralleling. Did you see this slide here?
Yes.
Okay. All right. Did you hear about the XCP?
Yes.
Okay, great. Okay, here's an example of the XCP setup in the patient's mouth. Basic principles. The receptor must be flat. You want to cover the prescribed area of interest. The receptor must be positioned parallel to the long axis of the tooth. That's very important for paralleling. The central ray of the radiation beam must be directed perpendicular to the receptor and the long axis of the tooth, which is 90 degrees. The central ray must be directed through the contact areas between the teeth. Of course, we want to see mesial and distal of the tooth. The X-ray beam must be centered over the centered over the receptor to ensure that all areas of the receptor are exposed. Okay, here's another shot of this achieving parallelism, and this is a very important point. This was on one of our quizzes. The space between the receptor and the tooth, that is the object to receptor distance. As it increases, so that space between the tooth and the receptor, as it increases, the image magnification or distortion also increases. So the farther the receptor is from the object we're trying to get on our image, the image we're trying to get, the longer that space is, the greater the distortion will be. So the goal is to have a very small space here. All right. You want to be able to achieve parallelism. If we don't, of course, we'll get foreshortening or elongation, depending on how that device is, how that angle is changed. If the receptor is not more than 20 degrees out of parallel with the tooth, the face of the PI is exactly parallel to the receptor, and diagnostic quality of image can be obtained. Okay, beam angulation. When the X-ray tube is pointed up, you should understand that that's called negative vertical angulation. When the X-ray tube head is pointed toward the floor, it's called positive vertical angulation. And if you look at the side of the tube head, you can't really see it that well, but maybe you can blow this image up and you can see it a little closer down here. Let's see. Is this screen getting bigger? You can see some little indicators on the side there of the unit going around the access point where the tube head will pivot, and in degrees, and that's really what gives you these numbers here. Now there's some numbers the ADA has put out that will give you some angulations that standard angulations you should know for the different teeth in the mouth when you're taking an anterior shot or premolar shot or a molar shot. So you should know what these negative vertical angulations and positive vertical angulations are. It's a pretty simple concept. It's not that difficult to understand. Okay, these are the receptor holding devices. Of course, we're using sensors now. So all of these devices will hold sensors. these are actually film-based XCPs and what we call a snap array on the left. Snap array is a great device. When I was a student, that's all I took to radiology to take my imaging. We XCP was pretty new 30 some years ago. But anyway, the snap array is a device you would probably use to use your bisecting the angle technique, and that's the one on the left. But of course, the device is designed to hold the sensor now. This is just kind of an older imaging devices, but the same concept. Okay, here's a digital receptor. Again, or imaging devices. Okay, here is an FMX. At Howard, we usually do 20. Sometimes we do 18 images. And the FMX should include any edentulous areas. Just because there are no teeth in the area, that doesn't mean we don't want to examine the supporting structure there. But if there's a great deal of edentulous area, there are other forms of radiograph we can use, and pan is the image of choice in that regard. When there are just a few teeth, we'll take selected PAs and take a pan. Okay, here are some common problems with actual film-based technology. You can see some common errors here. With sometimes when you put these images in the mouth with the devices I showed you before. So like when you're using the snap array or one of these devices, sometimes the corners will get bent and you'll get this distortion. And then also another issue that students have, even with the XCP, I see this a lot with imaging with students. The plane of the teeth, the occlusal plane, is at a 40 or 45-degree angle across the image, and that's not really how we want to see an image. And then, of course, it cuts off the apices of some of the teeth when they're set up like this. So we want that occlusal plane of the teeth. We want it on the bite tab, and you can kind of see the bite tab or the XCP, whatever they use. This might have been a snap array. I'm not really sure what they took this image with. So we want our imaging to look like this. So we go back to the FMX, and you can see the occlusal plane is more or less parallel with the edge of the image. Okay, so let's move on. So let's just very quickly, any questions? Okay, let's keep moving. Here's a vertical alignment error, and then you can see the elongation. And you should understand how this is achieved and why you get elongation. And basically, it has to do with the position of the central ray and the angulation of the sensor. And you can see how in the diagram on the right, how the sensor position has changed in relation to that central ray. So on the left side of that diagram, you see the central ray coming through the tooth at a perpendicular angle in the correct way, but we have the sensor at a 30 or 40-degree angle, and so our image will look elongated. Then there's one other way we get elongation, is now the sensor is parallel or in line with the central axis of the tooth. but the central ray is at an angle. And so these are the reasons why we get elongation. And if you take a good look at this image, you should be able to identify and see. In other words, if you draw a diagram across the parallel to the central ray and the tip of the tooth, I wish I had my eye pencil. I don't. You can kind of see if all the rays are going across that tooth. You can see on the right side how the apice is actually going to miss the sensor on the right side of that diagram. It's going to miss the sensor, and that looks very similar to the actual image, radiation exposed image on the left. So I just want you to understand the concept. This is a board information. And again, this image right here is what happened to these teeth and explain how it occurred. And you should understand that the image on the right where it says beam underangulated, that's this right here, this image. Okay. So again, here is another problem with that angulation, and you can see here the central ray and the position, the PID, and how the operator is holding it in relation to the XCP. And you can see that the tip is not parallel. It's not meeting up with the ring, and there's an angle discrepancy there. So that will give us one of these problems here. Okay, so let's spend some time to understand this concept. Oh, I skipped over. Understand this concept, and it'll help. Now, we'll go over foreshortening. Foreshortening is the opposite of elongation, I guess, because now the tooth will appear shorter. And you can look at the image where it says foreshortened, and you see all the teeth look kind of small. And then one other thing that you can see here is you can tell easily why this is foreshortened, because you can see all of the cusp. You can see the cusp on the lingual and the cusp on the buccal of those teeth, those posterior teeth. And they should all actually overlap one another, and you shouldn't be able to really see the occlusal surface like this at all on a properly taken, a properly positioned image. So foreshortening is the result of overangulation of the X-ray beam. Again, foreshortening is the result of overangulation of the X-ray beam. And you can apply those imaging and how the central ray goes through the tooth, and that kind of gives you an idea on why it tends to look short, because we are how we have the beam overangulated. And then here is a positioning error for the maxillary central, how they're taking it. You can see the difference in the angulation between the end of the tube bed and the ring of the XCP. Bisecting the angle technique. Here is just a little graph on how the aiming of the central ray of the X-ray beam at right angles to an imaginary line. And just understand there are two right triangles. You can see B to D is that imaginary line. And if you can understand the concept, and if anybody, this kind of thing that we probably need to go over individually. So if you have a question about this, just email me, or we can have a little private session to help you understand this concept if you don't understand it. And here is another graph on bisecting the angle. So you should know all of this by now. Okay. Radiographic images. If I got into hold on one second. Okay, radiographic images are used to evaluate growth and development, tools for determining landmarks for root canal therapy and or implant placement. We've kind of talked about this stuff already. Does not determine the depth of a lesion. So when you're doing caries lesions and things like that in the teeth, you can't really determine the depth of a lesion. And why? Because usually there has to be about 40 to 45% of demineralization that is taking place for you to be able to appreciate that on a radiograph. And that means that there's quite a bit of decay or demineralization process that's gone on before you'll be able to see it on a radiograph. So you actually have to go in clinically. So you have to remove that decay to actually see how deep it is. So that means treatment at that point. It's the only way you're really going to be able to tell for sure. And also mucosal tissues are not really seen on a radiograph. You kind of see an outline of them, but you can't really use that for diagnostic purposes. And then also they're used to illustrate periodontal disease. Okay. Varying displays. Inflammation displays. So you'll see reactions to injury. That's how the bone actually deals with inflammation. And we talked about this in, I think, the last lecture. And what we're going to see on an image is really the difference between laying down of bone and the loss of bone. So bodies taking bone away and laying down new bone. That's how you're going to see it on your radiograph. And then trauma, when you see trauma or broken jaw, something like that, you'll see a radiolucent line, and you might be able to see the cortical borders will look different. So here's a good example of both of those. So what condition is this? This is probably osteomyelitis. And with osteomyelitis, we get this separation of bone. The body is actually trying to get rid of the disease, so it's kind of pushing it off, sloughing it away, kind of the way skin cells slough off of your body. They're constantly coming off, and the bone is kind of going through the same process here, and it's sloughing away the diseased bone, and then it's laying down new bone. So if you look at B, you see the almost look at the layers like an onion peel, layers of bone, and these little radiolucent breaks. And here we have a fractured patient that has a broken jaw, and you can see the radiolucent line. And then at the inferior border of the mandible, you can see actually the break on the left side and how it appears on the radiograph. And then if you look at the right side, you see a plate that's been put in place so this patient probably had a break on one side and they repaired that, and then something happened again, and then they got a break on the left side, and they're in to get that side repaired. Rough life for this individual. Okay. what we need to have a good image, we need sharpness, we need spatial resolution, and we need to understand the concept of penumbra and how that helps us to get that. So sharpness measures how well a boundary is between two areas of radio density. Spatial resolution measures how well a radiograph reveals small objects that are close together. So you want to be able to see, the difference, let's just say the difference between the S and the P in spatial resolution. So you want to be able to see the difference between the periodontal ligament and the tooth itself, or the bone. Penumbra is that zone of sharpness. It's that resulting blurred zone at the edge of the image, which causes a loss of image sharpness. Okay, so make sure you understand penumbra and you understand umbra. I put this slide in here, even though we didn't talk about this summer. I think we talked about it in the fall, benign and malignant tumors. So you should understand the difference between two. They're well-defined small borders that may cause pain or paresthesia. Benign lesions tend to be, I call them pressure lesions. They apply pressure and they expand in that fashion. Malignant tumors are more destructive. They destroy by growing, and they grow the way they want to grow, despite the tissues around them. So go into your textbook and take a look at benign and malignant tumors and make sure you understand the definitions, and then understand how teeth can be displayed with benign tumors and how teeth can be displayed with malignant tumors. Malignant tumors, you'll see the tooth just floating in that space generally. Sometimes, I'm sorry, with benign tumors, you'll see the teeth just floating a lot in the space. And with malignant tumors, the tumors just go right around them or right through them. They will destroy the teeth as well, just like they're destroying the bone around it. So make sure you go to your textbook and review benign and malignant tumors and how they can present. No radiographic errors, and we talked about a couple of those already, the foreshortening and the elongation, and why radiographic types are used for certain procedures. So you should know which type of imaging we take for certain things, and then what types of errors you can get. You should know the types of errors you'll get with pans and with panoramic radiographs, and which type of errors you get with bisecting the angle, and which type of errors you get with paralleling. We just reviewed some of that. Okay, here's basic dental anatomy. You should be able to identify all of these things on any type of x-ray that I show you, or image, or any image you're presented with. You should be able to know what the enamel is, what the dentin is, what the pulp cavity, what the root canal system looks like, and how you should be able to identify that amelocemental junction, the periodontal ligament, the lamina dura. I talked to you earlier about these guidelines for angulation. The tube head pointed downward is positive angulation. The tube head pointed upward is negative angulation. And here's here's the actual angulations that should apply to those areas of the mouth or the teeth that you're looking to acquire on an image. Patient positioning, the maxillary region. We want the occlusal plane parallel to the floor, and the sagittal plane of the patient's head is perpendicular to the floor, and then the mandibular region. Basically, you want your whatever plane that you're trying to get, you want it the occlusal plane kind of to match the plane of the floor. You want it parallel to the floor. If you're trying to get the maxillary parallel to the floor, you want to get the mandibular, you want it parallel to the floor. So that means you need to tip the patient's head back. If the mouth is open, you have to tip the patient's head back to get it parallel. So just understand that concept. I'm not going to continue to go over bisecting angle. We talked about that. We talked about that. We talked about bisecting and radiographs. The rules for bite wing technique. You can go through that. Take a look at this. Here's a vertical. Here's an example of your bad angulation, and one of the ways you can tell this is you can see the cusp on the right side of the teeth, where on the left side they kind of overlap a little more. Actually, yeah. So just look for those cusp tips. As long as they're overlapping, generally you have zero or very little angulation. Okay. Dr. Taylor, are you on? Jamila? Dr. Taylor? Okay, these are Dr. Taylor's slides. I wanted her to do this stuff, but radiographic quality assessment, so just bear with me. I'm going to try to get through this. So we want to make sure that we have good quality imaging, and one of the ways we do this is a concept about inverse proportionality. So make sure you understand that concept on the left, and you can see the I1 over I2, D2 over D1, and the squaring and how that works. Okay. Underexposure. These are some of the things that give us underexposure. These are more board questions. You should make sure you understand these concepts. What insufficient milliamperage gives you, what insufficient KVP gives you, what insufficient exposure time gives you, what film source distance is too long. So from the film or the receptor to the source, which would be the tooth, when that distance is too long, okay? When the film packet is reversed in the mouth, that we don't have that too much anymore. We're using sensors, but actually I have had students put the sensor in backwards, and then we get this little image of, it looks like a little computer chip. So it does happen, even with the sensor. So here is a shot of an excessive MA, excessive KVP, excessive. These are overexposed, and you can see the darkness of the film. Okay, we have intraoral bite wings now, and what we hope to get and what we should see. So approximately 35% demineralization of the enamel is required for radiographic detection of a lesion. Make sure you understand that concept. As long as that number might be from anywhere from 35 to 45%. Okay, so understand that you need about 60 to 65% of the tooth structure there for it to be captured. Here's some more information on the E1, E2, D1, and what they mean. Make sure you understand those concepts. Here we have clinical presentation, what it would look like, the moderate presentation of enamel, so the visible signs of enamel breakdown. And I think one of the quiz questions was we had on there was about the what your first sign of a cavity is. So make sure you review that. It's probably in this lecture. I'm actually going to try to review the quizzes at the end if we have enough time. I'm going to go over a couple of the quiz questions. And here's in the radiographic presentation. You can see how you can see those two triangles there in the enamel, that triangle, the enamel, and then again from the dentin layer of the dento-enamel junction, you see the base of the triangle again, and then the apice of the triangle, the pointed end of the triangle going towards the pulp. So make sure you understand these concepts. Okay. So overview and indications for panoramic radiography. Provides a broad coverage of the maxilla and the mandible. One of the big, I guess, positive factors for really getting a good understanding of what's going on and an overview of what's going on with the patient's jaws and the paranasal spaces. It allows you to assess the third molars, allows you to assess trauma, gross TMJ assessment. And there's actually the old style pan units or even the pan unit we have here at the clinic. It allow you to take an open and a closed view of the TMJ, and you can evaluate the spacing and kind of get an idea of what's going on with the joint. One of the other big positives here is the patients that can't tolerate intraoral radiographs. They can you can use this imaging to help them. You can take this image and get an assessment, and then maybe take a selected PA to assist you with your diagnosis. Sometimes patients can't open. They come in, they've got a bad infection, they have trismus, or they have, for whatever reason, they can't open their mouth that well. And then some patients have gag reflexes, those kind of things. So the pan is be your image of choice. Okay, theory of the panoramic radiograph image formation. I'm not going to go through all of this. You can go through this slide and take a look at this and make sure you understand these concepts. Here's a image of the exact area that we're trying to capture when we take a CBCT and PANS. We're trying to gather the information of this area called the focal trough. Okay, we just really want this image. What's going on inside that orangey area, which would include the mandible. But when we take these images, we actually get everything. We get all the soft tissue, and it's all overlapped. So you see the right side you see a ghost image of if we look here at the left side, you're going to see a ghost image of the right side on top of the left side. You also can see the airways, the radiolucent areas of the airways. You can see a lot of things. You see the spinal column, and you see so many things here. So again, you have to look at a lot of these images and keep looking at them so you can really appreciate what's normal and what's abnormal. Let's go back here to our slide here. So there's certain things that help us set all this up. These machines usually have laser lights, and they have other little devices to help us get the best position of the focal trough. The way these units are set up, the head has to be in a certain position to give you the correct image. So the laser lights, and with practice and setting the patient in the unit, it gives you a good image. If we look back here at this image, you can look at the position of the teeth and you can tell that this, I call it the little slight smile. That means the head is in a pretty good position. If those anterior teeth are more superior or more up, then you start to get this flat looking image. And you can tell that, oh, wow, the patient's chin is up too high. Oh, and I'm getting that type of distortion. Or if they get a really big smile when the maxillary anterior teeth, the centrals are further down or inferior. So the head, you can tell that the head is positioned in a downward position. And again, that's the Terminator smile, I call it. You ever watch that movie, Terminator, had that like weird looking smile. So anyway, you pay attention to those things. So here is a slide that explains the positioning of the panoramic unit and how it rotates around the mandible and gives us the image of the focal trough. And you can see the panoramic head there in the right image, on the right side image, or the one with the A in it. That's on the right side. So you see the X-ray tube head, and you see the sensor on the opposite side of the head. So these machines have what they call rotation centers, and they'll rotate and pivot. And if you see the little dots there, that shows how the unit is actually rotating around the arrow and then the dots and where it actually will pivot. So just understand that these machines, some have 2 or 3 pivot points. And when you're actually taking the image, you will actually see the tube head kind of move to a position, and then it'll kind of stop and slide. And that's usually where it's adjusting its what they call center of rotation or pivot point. So ghost imaging, you heard me say before, you get what you see on the left side. If you look at the actual image of the left side, you actually have ghost imaging from the right side on top of the left side. So just understand that. So whatever side you're looking at, you're going to have the ghost image of the other side. And I think there is in the slide presentation in the class, there was a shot of an earring. And if you look, a hoop earring that the patient had on when they took the imaging. And that, though, of course, they should have been removed, but they were taken. And you can see how one earring matches up with the other side, and you get to see the ghost image on the other side. So just make sure you understand those concepts. Here's the Terminator smile, and you can kind of see how the chin is probably down with this particular image. And here's the earring shot. You can see the right earring, and then you see where it says ghost image of the right earring and ghost image of the left earring. And then another thing, if you're also on the left side, you can see the ramus of the mandible looks a little wide on that side, and that tells you that the head was turned a little. So make sure you go through this and you understand these panoramic errors. Okay, these are some checkpoints. Tongue at the roof of the mouth will present with a radiolucency across the palate. Make sure you understand that. Here is a checklist for you to go through. Just make sure you understand how you get each one of these image problems. Okay, that's the end of Dr. Taylor's slides. Okay, here is a slide on displays of inflammation, and you want to understand why we get these displays. Of course, this is a reaction to injury. It's an imbalance between osteoclastic and osteoblastic material. I think I said that already. The effect to inflame the surrounding cancellous bone includes the stimulation of bone formation when lesions exist. And you just go through this. Saying this stuff, we've already talked about this. Here's some more information on benign tumors. Malignant tumors. This is the information I told you to make sure that you go through your go to your textbook and review that. Cervical burnout. These are these decreased areas of radiation, X-ray absorption, actually. So the X-rays pass through these areas of the teeth, and we get a lot more darkness in those areas, and they tend to look like cavities. So we have to be wary of that, and just take if you see something like that at the CEJ on a tooth, rather than saying that's a cavity, of course, you should always take your Explorer and go in the area and check it. And usually you'll find that there's no cavity there. So make sure you understand what cervical burnout is, okay? Here's just a little slide on periodontal disease and assessing the things we're looking for clinically, because you can't appreciate these things on a radiograph. You can't see bleeding. You can't see how deep the period pockets are around the tooth. You can't see edema. You can't see erythema. You can't see gingival architecture. So it's very important that you have, in perio, you have to combine your clinical information with your radiograph. The radiographs for periodontal disease actually allow you to see the amount of bone, but remember, you can't see demineralized bone that well. Sometimes it's there and you won't see it on the, of course, you won't be able to see that on the radiograph because it will just show up as a darker area. You can evaluate the condition of alveolar crest, and you can evaluate bone loss in the furcation areas, the width of the PDL space, and the local factors, which in the field with periodontal disease. So what's a local factor? Like calculus, you'll be able to see calculus on the X-ray. Okay, you'll also be able to see the root length and the morphology, the crown to root ratio. You can evaluate the sinuses, the teeth, and whatever contributing factors that some things that you can see, like again, calculus and maybe overhangs from restorations and those kind of things. Caries, apical inflammatory lesions. So if it's got an abscess or if there's a darkening around the apices of the teeth, you'll be able to see that. You'll be able to see root resorption also. And here's some limitations of radiographs. So the conventional radiographs provide a two-dimensional image of a complex three-dimensional anatomy. So these are some limitations. So you can't see some of these things that well due to superimposition. The details of bony architecture may be lost. Radiographs do not demonstrate incipient disease, as a minimum of 55 to 60% demineralization must occur before radiographic changes are apparent. Just remember that, these numbers, these concepts, what your limitations are. Radiographs do not reliably demonstrate soft tissue contours. You may be able to see the gingival architecture a little bit between the teeth and that kind of thing, but you can't really use that reliably for diagnostic, for you to actually establish a diagnosis with. But sometimes it can help. So bone height within 2 millimeters of the CEJ. So I think we had a quiz question, 1.5 to 2 millimeters of the CEJ. Crest of bone is a continuation of the lamina dura of the teeth and is continuous from tooth to tooth. Between the anterior teeth, the alveolar crest is pointed in a normal, healthy mouth. As you get older, those little pointed areas, they deteriorate. So sometimes you can even age a patient by looking at some of these radiographs, actually. If you get into forensic dentistry at some point, some of you may get that experience, and that could help you age a patient. Anyway, posterior, between the posterior teeth, the lamina dura and the crest of bone form a box with sharp angles. Okay, here's a shot of bite wings. There are some, there used to be, well, we won't get into that. Here we have the adult bite wing, and the amount of teeth you get, three to four teeth on a bite wing shot. Here's the children's size imaging device, and then there are vertical bite wings, which are used in perio. Dr. McIntosh, who runs perio department here, will request these. Some of the dentists do request them quite a bit here at the dental school. In private practice, I said this in class over 30 some odd years, I never took a vertical bite wing. But like I said, some people do have a preference for this. Okay. They can be difficult to get with the sensors also. Not so hard with film, but more difficult with the sensor. Here's a shot of the bite wing shot. Bone responses, periodontal disease causes inflammatory lesions in the marginal bone. Again, here we can say again, the osteoclastic activity is seen. The short responses, destruction of bone, chronic lesions will show some osteosclerosis. So that's that laying down of bone around the area. So here's some local factors we see: calculus, overhanging restorations, poorly contoured margins, foreign bodies. Here's an overhanging restoration, and then you can see the arrow number 2 shows a little radiolucent area, and that's directly related to food and bacteria packing into that area under that overhang. Okay, mild periodontitis, here's a description of that. Please go over these points. There's moderate, more points, and severe. So make sure you understand these differences between these three categories. Vertical bone loss, you need to know what that is. Infrabony defect, make sure you understand that, what it is. Furcation bone loss. Here's an example of all three. Number 1 is the vertical, number 2 is the furcation, number 3 is the horizontal bone loss, I guess. This. Okay. Make sure you understand the definition of furcation bone loss, the definition of periodontal abscess. 1 point on periodontal abscesses, generally they are right at the gum line clinically. They might be just maybe 2 or 3 millimeters below the gum line. And then the periapical abscess tend to be more the middle to where you would think the apices of the teeth are. It's just a clinical sign, something for you to think about when you're actually seeing these things. And then, of course, you can use, if you're not sure where it's coming from, you can just rub a little topical on the patient's that abscessed area, and then take the end of your Explorer and poke a little hole in it. And you take a piece of the orange gutta percha, that point, and just poke it right through that opening and just keep pushing it and inserting it. You might have to go up and down a little bit to get it to follow the drainage, the little drainage area to back to the source. And a lot of times you'll find that these abscesses, especially the periapical abscesses, they will be next to the tooth that's mesial or distal to the actual point of the origin of that, of this, the source of the infection. So that's always a good way to figure out where the abscess is coming from. Localized JP, I'm going to tell you, you should know what this is, but I understand that. I think now that Perio is not teaching this, but this was an older concept about periodontitis and how it affects patients sometimes. I see this, I've seen this in my office many times, actually. I come in a lot of times, patients have perio around all their first molars. So a concept you should understand, but it won't be on the test. Here's a shot of JP. You just get this. This is what you see. You'll see it in the mandible on both first molars, sometimes in the maxilla. Occlusal imaging, supplemental imaging technique. Sometimes you can't get an image on a kid, so we'll have a large image device that we'll use to actually take the whole mandible or maxilla. And sometimes this is the only way we can see under the tongue and what exactly could be under the tongue. Sometimes you get stones, salivary stones, and other things that can only be imaged with an occlusal device. I don't know that there are any companies that make sensors this big. Sometimes I developed a little sensor holder where I can put two sensors together and take one image in my office. That's just something I've been working on. But I don't know that there's any device out there that gives you one large plate that allow you to get an occlusal image. Usually you have to use X-ray film for that. And they're large films, maybe about half the size of your cell phone. And you can just put that right in a patient's mouth, tip the chin down or up, depending on which arch you're trying to capture. Here are the uses. So make sure you understand the uses of occlusal film. Here's a shot of getting into the maxillary, and then shot of the mandible. Here's some imaging showing some issues and why we need it. You can see the salivary stone. You can see the palatal lesion and how it approximates the center of the maxilla there. It's really a good imaging device. Okay, criteria of quality. So these are the things that you need to take place to make sure that you're getting a good image. A lot of times we take images and at the very edge of the image, you'll have the border of or you'll have the apices way down at like in this image. This is a good image, but you need to have 2 or 3 millimeters beyond the apices of the teeth. And then you also want the occlusal surface of the tooth. So you want the entire tooth on the image, not just part of the tooth. So if you can see there the cuspid tooth. So if I was trying to get let's say the patient had a problem with the first bicuspid. Usually you want the tooth next to it. So the first bicuspid is not in the center. The second bicuspid is. And that allows you to see the tooth in front and behind of that. And that's kind of what you want for it. So if I wanted the first bicuspid, this would not be the correct shot. I would need to retake that and center that first bicuspid in the center of this film for it to be considered a good shot. So if a pathological lesion is present, the radiograph must cover the complete lesion plus some of the surrounding normal bone. The radiograph should have the least possible amount of distortion. The images should have optimal density and so you can, and contrast, so you can make a good interpretation. Okay, make sure you go over these periapical radiolucencies. Go and find some imaging on radicular cysts, what a periapical abscess looks like, what a chronic apical periodontitis looks like. You can just type this into your Google and Google radicular cysts and hit images, and then you will be able to go and it'll show you a lot of different radicular cysts, and make sure you understand what some of the what the definition of each of these are, what they mean. Also, make sure that you understand the mental fossa and where it is in the mandible, and how it appears on a pan, and how it appears on PA, and where it is in proximity to the roots of the first bicuspid and second bicuspid and the canine. It's important that you understand where that point is. A lot of times people want to call it abscess tooth and things like that. That's why I'm pointing that out to you. Okay. Okay, periapical inflammatory lesions. You want to understand the early signs and what you see, the location, the shape, and the border. And these are the radiographic descriptions that you should be writing in your note. You want to describe that in your note when you make a statement about what you evaluate on your image. Make sure you also know the definitions. We talked about rarefying osteitis, and make sure you go over that. And sclerosis that you see around teeth that are infected by inflammation. I already talked about that earlier. Here's some descriptors. So when you're writing your note, you want to write the location, the density, whether it's radiolucent, radiopaque, the size, the shape, the borders, is corticated or non-corticated, what the internal structure looks like, and the surrounding tissues, what kind of effects the lesion could be having. Are the teeth, do they look displaced, or do the roots look eroded because of the lesion, those kind of things. Conditions mimicking apical radiopaque inflammatory lesions. So just go over all of these terms and make sure you understand what they are. Enostosis, you should know the definition of this, what this is. Any questions? No questions? Okay. Well, thank you very much. And good luck on your exam. I'll see you next week.
Thank you.
Thank you.
All right.